I'm Greg England. I'm a cardiothoracic surgeon here at Bay Medical Center. I've been practicing here for a little bit more than 16 years. We always are trying to learn and do new techniques, apply new technology to the care of our patients. Most recently, we've started our TAVR program. That's TAVR. It stands for Transcatheter Aortic Valve Replacement. We started in February. We did this week number 39 and 40. Those patients are doing well. And so we have really come along with that program. It's beneficial really in a couple of ways. First, it's a less traumatic. It's still a major operation, but it's less traumatic. We don't have to open the breastbone generally, and so you avoid the incision that usually goes with heart surgery. And we don't use the heart-lung machine, so there's not the pump run that's associated and the side effects from that. So it's less invasive, there's less discomfort. The patients generally recover quickly, more quickly. And it's another approach to treating aortic valvular disease. The most common cardiac operation we do at Bay Medical Center is coronary bypass grafting for coronary disease, and that's simply because coronary disease is the most common problem we encounter. But the second most common problem we encounter is valvular heart disease, specifically aortic valvular disease. And the most common aortic valvular disease is aortic stenosis. That's when the aortic valves become narrowed and it obstructs blood flow out of the heart. And when it starts out, it's mild and the heart has plenty of reserve and it's not a problem, but it progresses over time. And eventually it reaches a threshold the patients start to become symptomatic. They start to have heart failure or start to have chest pain or passing out spells. And that's when it's become very severe and the valve needs to be replaced. It needs to be replaced because if you don't do that, the process continues and it will shorten the patient's life expectancy. Traditionally, the only approach really was surgical aortic valve replacement, or SAVR, which required us to open the breastbone or partially open the breastbone, put the patient on the heart-lung machine and cut out the bad valve and replace it with a new one. And that's still the most common approach. But more recently, transcatheter aortic valve replacement has been developed and is used across the United States, including here at Bay Medical Center. It's a less invasive approach. Usually it's to the groins, but there's other access sites we use. And it avoids opening the breastbone in the heart-lung machine, and so it's less traumatic. Transcatheter aortic valve replacement is primarily for patients that are higher risk patients. When it first became about, it was only done for patients that weren't operative candidates at all, or patients that were high risk in their early studies were randomized to get either surgical valve replacement or transcatheter valve replacement. But we learned from those trials that for high-risk patients, transcatheter aortic valve replacement is just as good. And so that's really become the standard of care for high-risk patients. More recently, we look at intermediate-risk patients, and it's becoming really the standard of care for most of those patients as well. And then currently there's trials ongoing looking at low-risk patients. So now transcatheter aortic valve replacement is primarily for high-risk and intermediate-risk patients. When we see a patient with severe aortic valvular stenosis that needs aortic valve replacement, we do a fairly comprehensive assessment of those patients, and they're seen by our valve team. But we look at not only what is the status of their aortic valve, but you have to take into consideration the whole patient. You have to look at their other medical problems. Do they have lung disease? Or do they have advanced age? Are they diabetic? Do they have poor kidney function, etc.? And there's a risk calculator that we use that sort of tallies up all of those things and tries to assess the risk for a patient going into an aortic valve replacement. And if their expected mortality from the surgery is greater than 8%, that's a high-risk operation. If it's between 3 and 8%, that's intermediate risk. And so it really just tries to take into consideration not just the patient's cardiac disease, specifically their heart valvular disease, but their overall, all of their medical illnesses. Cardiac surgery, and really it's probably more appropriate now, it's cardiac care. The care of patients with heart disease is evolving. It's evolved since we started doing open heart surgery decades ago. But more recently, it's really becoming more of a team effort. There's a lot more and more overlap between what cardiologists do and what cardiac surgeons do. And a very good example of that is with transcatheter aortic valve replacement. That is really done by a heart team. All of those patients are evaluated by cardiologists and cardiac surgeons. And the procedures themselves are done with both specialties hands-on at the table working on the patient. There's two cardiac surgeons here at Bay Medical Center that participate, and two the cardiologist, and we all participate in the cases. There's a cardiac surgeon and a cardiologist in every case, oftentimes more than one of each specialty. So it's more of a team effort. And these patients we meet, we do transcatheter aortic valve replacements generally every other week. We typically do 2, sometimes 1, sometimes 3, but usually 2 on a given day. But we meet every Wednesday, which is our transcatheter valve day, to discuss prospective patients and follow-up patients. So the patients are seen by the cardiologist, seen by the cardiac surgeon, but then they're discussed by the heart team to decide what the most appropriate approach is and get them on the schedule and plan the procedure. Because we have to decide what's going to be our access site, which size valve, all that kind of stuff that's involved.